Welcome back, everybody, to another episode of the Podiatric Dermatology Monthly Wrap-Up. I am your host, Joseph, and I'm joined by my co-host, Steph. G'day.
Hey everybody, hope you're doing well. Middle of the year.
Yes. Can
Getting
you
on.
believe it? We actually had just a funny little anecdote. We had a patient the other day who had a bit of a fall, and they asked her what year it was, and she said 2020. And I said, to be honest, I only just realized that it's 2023. So
I think we're all sort of stuck in 2020 in some way, shape, or form.
yes, absolutely. So for those joining us for the first time on the Podiatric Dermatology Monthly Wrap-Up podcast, try saying that very quickly. We talk about one case study from our Podiatric Dermatology interest group on Facebook, and we talk about one skin condition, a dermatosis, and we also feature one product. What are we talking about today, Stephanie?
Ooh, today we have a nail focus. So strap in for some really bad dad jokes from Joseph, because he had nail jokes coming out of his ears. So our case is we're going to have a look at a case of Melanonychia.
Mm-hmm.
Our dermatosis is medial canaliform dystrophy of Pella. And the product that we're looking at today is Urea, specifically focusing on how you would use it for nail rather than skin.
Yes.
And I am definitely convinced that Joseph chose all of these cases in dermatoses just to trip me up today. So thank you for that.
No, that's okay. I mean, we're here to learn, we're here to share. We're not here to highlight knowledge or ignorance in any of those aspects. So interesting case here that was shared by Saffron, who's a podiatrist over in the UK. Welcome to all of our international visitors. Obviously, you can tell that Steph and I are Australian, hopefully by our accents. So it's quite an interesting one. What's that? Sorry?
What are you talking about?
So Melanonychia, Steph, what does that mean to you?
Oh, that means usually figuring out whether it is a naturally occurring process within the nail plate or if they have a lovely little cancer going on in there, which is usually what patients freak out about, and
Absolutely.
less experienced practitioners as well. When you see a nice dark line on a nail,
Mm,
it's never really a good sign.
true.
And
Sometimes it even looks like that. That's an extreme close-up.
yeah,
But if we break up the word, and so much of dermatology, dermatoses rather, in dermatological terms are actually descriptive. So melanin is the pigment that's produced by melanocytes, and melanocytes are deep down in the epidermis at the dermal epidermal junction, and there are nests of melanocytes all around the body. And some of them do concentrate around the nail. And onychia means of the nail. So it's melanin of the nail. So pigment in the nail. And Steph's quite right, because in some cases you see them just in one nail, and in other cases you see them in multiple nails. And where things can get a little bit tricky for both patient and practitioner is knowing whether it's a normal variant or whether it's something to be worried about. So, courtesy of Dermoscopedia, this is a little flowchart that shows exactly what could be the cause of any pigment in the nail. So if we start on the very left, we've got, now for those of us joining us on YouTube, you can actually see this. It's whether or not we actually can see the pigment all the way down from the nail matrix, also known as the nail root. And so if you can see it from all the way down in the nail matrix, so it's one long continuous street from all the way, a streak rather, nail street, where podiatrists live.
yeah, definitely you live on Nail Street.
Then you go off to another flowchart. But if you see a disrupted pattern, it's called non-melanocytic, which means that it's likely to be either a subungual hemorrhage, which is also known as a blood blister, or it's some sort of infection, either fungus or pseudomonas or something else. But if we move over and we see melanin inclusion and we see an irregular pattern, that's suspicious for melanoma. Whereas if it's a consistent pattern, if it's one continuous band, or if you're seeing it across multiple nails on the one patient, then it's likely to be benign. But any form of skin pigmentation, whether it's in the nail or whether it's in a mole or something else, should always be monitored. Because things do change over time. So, Steph, do you notice melanonychia in particular patient groups?
Yeah, absolutely. When I was working in the primary care facility, which had predominantly, a very multicultural patient demographic, patients with darker pigment in their skin will get lots of melanonychia. And oftentimes they realize that it's something specific to them or their family, but they don't understand the cause of it. And so you'll sometimes have people saying, I don't understand why I've got all these streaks on my nails. And it's really nice to have that light bulb moment with them and to give them a little bit of education about, well, actually, it's just normal for your type of skin pigment. You've got more melanin, not a dressing, and that can present within the nail as well. So it's always good to keep an eye on it though, and to look at that stripe and whether it is regular or irregular, and if it's on multiple nails, because it's not unheard of to also have subungual melanomas in this patient demographic as well. So you still, you can't just be dismissive of it and say, oh, that's just melanonychia, it'll be fine. Always err on the side of caution and trust your gut. If something doesn't look quite right, would rather send them to their GP or to a dermatologist to get that checked, rather than just assuming that it is just a naturally occurring deviation.
Having seen a few cases of nail unit melanoma, you never do quite forget when you actually see it for the first time. One patient in particular, he ended up losing his entire toe, so his big toe, and the big toe, when it comes to, and we'll have to do a focus on skin cancers in one episode, but the big toe seems to be the most prevalent. And yeah, he was actually mismanaged and misdiagnosed at a number of different stages along his care pathway, which was quite sad. But certainly the atypical appearance, or if it starts to ulcerate in any way, or if you're noticing the band is inconsistent, starts to widen in a V shape, that's definitely a red flag. And I had a real uptick in patients wanting to check out their nail pigmented lesions around the time that Bert Newton had his leg amputated. So yeah, positive messages there, certainly, about checking out different colored lesions.
Isn't it? I've had an uptick in patients terrified of hip surgery after Barry Humphries clocked out. So yeah, it's definitely something to be aware of, and it's good discussion points.
Absolutely. So continuing on with the nail theme, what are we talking about next?
Next, we're having a look at a particular condition, which is medial canaliform nail dystrophy. I'm
Yes.
so impressed with myself.
And there it is.
I managed to say it correctly each time so far.
Medial canaliform dystrophy. I think of Hella. I don't know who Hella was, but he had a hell of a good idea naming it after himself.
Oh, God.
The dad joke meter has just ramped up to about 15. Okay. Yeah, absolutely.
Oh my goodness.
Okay. So which nails do we typically see this in, Steph?
In the thumbnails, funnily enough.
Yes.
It can occur in the toenails, but usually bilateral, but can be unilateral in the thumbnails.
2 thumbs up.
Well, you want to be doing it towards yourself if you have this kind of condition.
Yes, yeah, correct. It is quite visible. There's a number of different variants of it, and it can be both trauma induced, which is the most common version, but can also be idiopathic, which means we don't know why you have it, you just have it. Yeah, so it's an interesting one. You do typically see it in individuals who have a big lanula. So for those that want to know what that is, that's a part of the nail that looks a bit like a moon. That's why it shares a similar etymological root. So the lanula is the place of
sounds like something out of an Adam Sandler movie.
Lanula, correct.
Lanula.
Right. So in those that tend to get this, it's repetitive trauma down by the nail, sort of near the cuticle, also known as the eponychium. So if you continue to traumatize the cuticle and you continue to shove little probes up there or pick at it or insist that your pedicurist / manicurist / podiatrist removes that cuticle, that can cause the nail to do all sorts of funny things. And I think, Steph, you mentioned to me, it goes in a bit of a fan-like pattern.
It does. It's almost like, what do I say, a fir tree pattern. So it kind of spreads out from the center, and you can see it. I think I've seen better pictures than the one that we've got. Put you on the spot, Joseph, but if you want to have a look on DermNet, this
Yes.
is from DermNet as well, but we love DermNet. They're an amazing resource. They've got some really good little photos on there where you can see it does just look like a fir tree, or like almost like a little Christmas tree on your nail.
Absolutely. And what has this got to do with pastry making and frosting and icing on cake, Steph? Because we talked about this just before the show.
Very tenuous link. I'm not sure that I love this analogy, but it'll work.
I'm going to share it anyway. Okay, so the nail, just very briefly, the nail plate, i.e. the top bit of the nail, which is the bit that you cut, is very much determined, the shape and the thickness and the curvature is very much determined by its environment. So it's determined by the nail root. It's also determined by the nail bed. It's also determined by the other local anatomy, like the bones. And so what can happen is, if you have an altered shape of the nail root or of the nail bed, the nail will get thicker. It'll have dystrophy. It'll have lines potentially. It may even discolor. And so the best analogy that I could come up with, maybe it's because I like cakes, is that there are different nozzles on a piping bag. And so even though you have the same sauce in that nozzle, i.e. some lovely buttercream frosting or whatnot, the shape of the nozzle will determine what comes out of it. And so it gives you an idea of the underlying cause and the direction which things go in. So I don't know. Is that helpful for you, Steph, next time you're baking?
Oh God, I don't really want to think about my patient's nails when I'm baking. I love baking. It's the way I switch off. Is there a reason why it is centrally located? Is it kind of like, the apex of the curvature of that nail bed has something to do with it? Like you're more likely to traumatize the more raised section of the nail, or anything?
Potentially. Yeah, potentially.
See it more in patients who perhaps have involuted nails, so they're getting a lot of pressure through that apex of the nail?
I would say so. Because there and if you think about involuted nail pathologies, like you think about psoriatic nails that become quite involuted, the middle band of the nail plate is actually the thickest, which does make sense. So it would also have to do with the actual part of the matrix that's most exposed in terms of the repetitive trauma. And so if that's the part of the matrix that sits closest to the skin and that's the bit that gets re-traumatized, that would then influence how the nail plate is actually growing outwards and bubbling up on itself.
So, I mean, not having had much experience with this, my immediate instinct as a podiatrist, if this was something that is quite raised, is almost like a fissure through the middle of the nail.
Good analogy.
I probably want to burr that to stop it from catching on things. Is that a correct instinct, or could that cause more trauma? Is that going to open it up to, any subungual ulcerations?
Yeah, excellent questions.
Is there a way to treat this, or do you just leave it alone?
Combination of all the above. So you do need to leave it if there's a traumatic component. So if it's self-inflicted, then you stop them from traumatizing it. But if it's that's I mean, it's easier said than done in some cases of those chronic onychotillomaniacs. That's the technical term for those who pick their nails. Correct. So stop doing that or bite them. Burring is very helpful. Burring is very helpful, because certainly from an aesthetic perspective, it helps, but also from a functional perspective, it stops the re-traumatization process. What tends to happen with onychocausis and onychogryphosis, which are broad terms for nail thickening, is that the thicker the nail gets, the more easily it's traumatized, and the more easily it's traumatized, the thicker it gets. And it becomes a positive feedback cycle of repetitive trauma. So certainly thinning it down periodically in the sort of 6 to 10 week time frame does make a difference. But also this product can be incredibly helpful. Urea.
Nice segue there.
Thank you. As we come up to
very smooth at this.
Thank you. I'm trying. Just as smooth as urea when you apply it to your skin. No,
Okay.
no product placement at all. So urea is quite an interesting product. It's actually a part of the skin's natural moisturizing factors, and it's contained in a lot of different natural products, but essentially it's a keratolytic. And depending on the percentage, it will determine how keratolyzing it is. What is keratolysis, Steph, when you hear that word?
Well, look, keratin. So you're thinking skin cells and lysis to lift.
Correct. Essentially, you're 100% right. So what urea does is, and we produce it mostly because it's a humectant. And what that means is it draws water in from the environment. So when we apply it externally, it not only breaks down skin proteins, also known as keratin, but it also draws moisture in. And so the higher the percentage, the greater the keratolytic property, but the lower the humectation property. So in other words, as soon as you tick over to 15% plus urea, excuse me, then you end up getting quite keratolytic to the point that 35% plus can even completely dissolve a nail.
Ooh,
Yes.
that's a handy trick to have up your sleeve.
It does. It's called chemical nail avulsion. If ever you want to remove a nail, a 40% urea plus on top of a nail and under occlusion, so with a really tight bandage, leaving it on there for a week, and you can remove the nail. It's called a total nail avulsion as a whole procedure. But anyway, what's this got to do with nails? I love the fact that I'm asking my own questions and then answering them. So
I can't get a word in. You love the nails.
I do. Oh, I'll speak very briefly. Urea can be really handy when it comes to fungal nail infections because it can keratolyze away nail. Then it can be somewhat selective for parts of a fungal nail infection, whereby those areas, rather than burring and picking and cutting and scalping them off, they can actually be slightly dissolved to enable a topical antifungal to penetrate deeper. There's one brand out there called Caniston Antifungal Nail Set. Steph, we were talking about percentages before we did this show. What was your question on that?
Yeah, I often recommend to my patients that they need to source a cream that I don't sell my own, that has at least 15% urea, but that the sweet spot is about 15 to 25%. And so for my patients who have got very thick callus, I'll often say, can you go for higher percentage, please? And then we'll have a reevaluate. Have you got a favorite concentration that you like to recommend?
I find that, great question. I find that 15% is the sweet spot because it's one of those interesting things when it comes to treating skin conditions that if people don't get results quickly, they start getting frustrated. Why isn't it better? I've put it on twice. So urea is one of those somewhat cumulative products in the sense that if you use it consistently and regularly, you'll notice the benefits of it. So I find 15% works well. If on the odd occasion I do recommend a 25% or higher, it's with careful monitoring and frequent reviews. Because what can happen is, over time, if you over-keratolyze the skin, you stop it from achieving its purpose. Now, the purpose of the epidermis more broadly is to be a big, fat, dead layer, quite literally. And some of that fat deadness is because keratin, I know it sounds awful.
It sounds so appealing.
I know it does. You can't even be a big, fat, dead layer, you silly
Look
skin.
after your big, fat, dead layer.
Is because if we remove too much of the keratin, then we stop some of that natural humectant properties within the skin. So it can be too much of a good thing. And so you can always increase and you can always decrease. So just play with it. There's a number of different products on the market that range all the way from 5% all the way up to 40%. So yeah. I find 15% is a nice sweet spot.
So what would you use a 40%er for if you wanted to get rid of a nail really quickly?
Yes, you would. I'm hesitant to use it on any skin lesions unless it's something that's incredibly thick. So certain skin conditions like certain keratodermas or even various clinical variants of various clinical variants. Well, that's a lot of use the word variant for psoriasis. But for other skin conditions, I would be wary. What's interesting is, and I think we'll end off with this, is that a lot of podiatrists and also other health professionals, even members of the public, would think that it'd be good for heel fissures, but heel fissures are often secondary dermatoses, meaning the cause of the heel fissure is actually something else. And so it's worthwhile looking, much like Melanonychia and medial canaliform dystrophy of Heller, it's worthwhile looking deeper to see what's actually causing the skin condition or nail condition that we're presented with. So,
Can I
yeah.
just go back briefly to, you mentioned the product, which is an antifungal. So that is a combination antifungal and urea?
So it's a staged process. So stage 1 is you would use the urea, and stage 2 you use the topical antifungal.
Okay.
Yeah.
Yeah, because that, I mean, it's so difficult when you're trying to treat fungal nails and you need to keep explaining to your patients. We're trying to reduce the fungal load, but if we don't get adequate penetration of the nail, it's just a waste of money, because you're just painting it on, or, you know, if you're not removing that layer of medicament each time, you're not getting to the fungus.
Correct.
So yeah, that's interesting that you can do that. It's a better alternative to either, you know, the little dinky nail files that they get in, say, a Losserol kit, or coming to you more regularly to have their nail burred and have that thickness reduced so that you can get adequate penetration of the medicament.
Correct. That's correct. Excellent point, Steph. So a final take-home bit of advice is pop into your local pharmacy and see what they have available. Have a chat with the pharmacist, see what products are out there. And there's no reason why you can't, with the right knowledge and combination of products out there, find the treatment regime that works for you and for your skin condition and for your patient's skin conditions.
Lovely.
I think that about wraps it up. Did we nail it?
Oh, there it goes again. And if you can't get enough of Joseph's terrible dad jokes, he's also presenting a workshop at the National Conference in Brisbane soon, which is when we'll be releasing this particular episode.
Yes,
so,
absolutely. So looking forward to
grown from terrible humor. You are most welcome to attend his workshop. Make sure you heckle him, please.
Yes, please. Yes. Save up your tomatoes from now. Thanks as always, Steph, for your insights, your knowledge, and your patience with my bad humor.
You're most welcome. We'll be back next month with another interesting array of cases.
Terrific. Thanks, everyone. Keep derming. We'll see you soon.